Good morning, everybody. Let me just start talking to you. I like interactivity, and to the extent that that's possible, I'd like to foster that. If not during, then after, because that's how I learn. So I'm going to tell you a little bit of a story about, if this thing works, and it apparently does, about how I got into this work. But first I want to read you a quote. And then I want somebody who doesn't know who said this to guess who said this. I will say then that I am not, nor ever have been, in favor of bringing about in any way the social and political equality of the white and black races. That I am not, nor ever have been, in favor of making voters or jurors of Negroes, nor of qualifying them to hold office, nor to intermarry with white people. And I will say in addition to this that there is a physical difference between the white and black races, which I believe will forever forbid the two races living together on terms of social and political equality. And inasmuch as they cannot so live, while they do remain together, there must be the position of superior and inferior. And I, as much as any other man, am in favor of having the superior position assigned to the white race. That was Abraham Lincoln, the great emancipator. Somebody describe what you see when you walk into the Lincoln Memorial. You see a statue. You see this statue. And what's on either wall, carved into what I assume is marble?
Emancipation Proclamation.
Emancipation Proclamation, Gettysburg Address. Not this. It would change our image of him. Those comments were from a debate in 1858, at which point he was running for the Senate and was articulating his position on race. And we celebrate this gentleman as the great emancipator. And it's part of a narrative that we tell ourselves about who our great heroes are. And I want to put it to you that that narrative is false. And that narrative that we try to convince ourselves is the narrative of equality and equity is in fact checkered with inequity and supremacy. This is the notorious third stanza of our national anthem. And where is that band who so vauntingly swore that the havoc of war and the battle's confusion, a home and a country should leave us no more? Their blood has washed out their foul footsteps' pollution. No refuge could save the hireling and slave from the terror of flight or the gloom of the grave. And the star-spangled banner in triumph doth wave over the land of the free and the home of the brave. And we wonder sometimes why there are different understandings of our core story about who we are as Americans. Now, I'm showing you all this in part because I like to provoke people. I like to get them to think, because to do this work, you have to be provoked. You have to be a little bit uncomfortable. I'm going to come back to this theme a little later on, but it's about this theme of narrative, the story we tell ourselves about who we are, and how that story shapes our policies and our practices. And those policies and practices create conditions, real-world conditions for people that make it either easier or harder for them to navigate health. And we end up treating those conditions in institutions like this without much of an understanding of what's generating those conditions in the world outside of the hospital walls. Okay, so the second question for me is why place matters. And I want to first describe the place where I grew up. It's a beautiful cosmopolitan city that is an island. It sits in the middle of a river. It's an old volcano. It is Montreal, Canada. Montreal, Canada is a very cosmopolitan city. I grew up in the 60s, 70s, and 80s in Montreal. This is a view of downtown Montreal with McGill University in the foreground where I went to school, and the St. Lawrence River in the background there. It's a city that hosted the 1967 World's Fair, the 1976 Olympic Games. You guys remember Nadia Comaneci and her perfect 10 in gymnastics? I was there. Don't think it was a 10. Canada has a strong social compact with its citizens. It's got universal health care. Universal. So I grew up in Canada. Everybody gets a little card. If you play a lot of sports like I did, you got a lot of stitches, which I did. You go to the emergency room, you present your card, they scan your card, and from that point on, you never see a bill, and you never pay a nickel. And it's all funded through taxes, and everybody is treated the same. It's got universal dental care up to the age of 10. It's got a universal child care benefit. It's got highly subsidized post-secondary education. I went to McGill University for free. In fact, I got paid to go to McGill. I got a scholarship that paid more than my tuition. But very high quality community resources, parks, rec centers, skating rinks like the one outside, literally on every corner. My brothers and I grew up in Canada. During the time period that I described to you, one brother became a university professor, I became a doctor, another one became a lawyer. We felt like the society invested in us. We didn't consciously think that, but we just assumed that that's what societies did. And then in 1985, I decided to leave Montreal to go to medical school, and I heard that Johns Hopkins Medical School was the best medical school in the world. That's what they used to say back in those days. Probably not true, but at Hopkins they have a saying, which is, we may not be the best, but there's nobody better. And so I figured, well, how bad can this be? I'll go to this great university. And I walked outside the doors of Johns Hopkins Medical School, and this is what I saw. Literally right outside the doors. And I was shocked. I was completely shocked. I had never seen anything like this. And I was being toured around by an upperclassman, and he saw the look of shock on my face, and he said, "What's wrong with you?" And I literally managed to stammer out, "When was there a war here?" This was when Beirut was in the news, and to me this looked like Beirut. It looked like bombs had dropped on the place. And I couldn't understand, how is this possible? There's nothing like this in Canada. Anywhere. I've looked everywhere, in every province. I cannot find this. And I'll never forget what he said to me. He looked at me with his look of total disdain, and he said, "What'd you expect? It's the inner city." And I thought, I was supposed to expect this. And there's a name for it. It's called the inner city. It's like where we sort of wall off our problems, where we put people that we don't literally care about. And I should expect this. This is a norm. And from that day on, literally my first day at Johns Hopkins, I've been struggling with this question about this country and the narrative that allows for this to be an expectation. And that's fundamentally what's at the root of health inequity. It's allowing these conditions. These are man-made conditions. Okay, and I wondered, what would I have been like had I grown up in East Baltimore as opposed to Montreal, Canada? Would I have been able to attend Johns Hopkins Medical School? Would I be talking to you today, here, now, if I had grown up in those conditions? I don't think so. And that's the point. This kid did not create these conditions. And the question for us is, what do we owe this kid? Okay, this is Baltimore more recently, which has basically been it's been a smoldering riot for 50 years. In fact, Time magazine asked that same question, is what has changed in Baltimore? So this is not history, this is today. And I put it to you, it's not just Baltimore or south side of Chicago or North Philly. We're now starting to see places all around this country with similar despair. This is Scott County, Indiana. It's not that far from here, I don't think.
I'm from there.
Oh, are you? Okay, so can you tell people a little bit about what's happening in Scott County, Indiana?
Really rampant rural poverty, significant prescription drug addictions, to the point that had an outbreak of HIV 2 years ago due to the sharing of needles. No needle sharing, no clean needle programs at all existed there culturally. And for the last 20 years, some of those are the most poor communities in the entire state of Indiana.
Yep. And it's not just Scott County, Indiana. Thank you very much, by the way. Scott County, Indiana has an HIV incidence rate that's greater than sub-Saharan Africa. I mean, this is as hot an epidemic of HIV as we've ever seen in the United States. And I put it to you that what we're seeing in Scott County, Indiana is the same thing that we've been seeing in East Baltimore. This is income inequality, for lack of a simpler way of saying it, income inequality in black and white. And this is the result of a weak social compact in this country. We let people suffer, and then we blame them. And then the healthcare system tries to manage this in 15-minute encounters. And that's the context. That's the context of health equity. Trust me, I'm going to cheer you up later, so don't be depressed. And so Alameda County's got 1.5 million people. It's got 17 different cities. It's got Berkeley and Oakland, some of the ones that you might be familiar with. Okay, so when you're the health officer, you're the registrar of all births and deaths. And in Alameda County, there are roughly 20,000 births every year, and there are about 10,000 deaths. And I got to the health department, and I was all green and excited about being the health director and trying to figure out what I was supposed to do. And there's no job description. It literally was just a physician job description. And so I thought, I'm not seeing patients, so what's my job? So I decided to make up my own job. And I did that by looking at Healthy People 2010, which was the Bible, is the Bible for public health practice in this country. It's put out by HHS. And it forecasts sort of 10 years into the future what our goals are. So it was around 2000, so we were looking at Healthy People 2010, and the first goal of Healthy People 2010 is to increase life expectancy for all Americans. And so I figured that must be my job. My job must be to try to increase life expectancy in Alameda County. And the second goal was to eliminate health disparities amongst various groups of Americans. And Healthy People 2000 had said, reduce. And because of David Satcher and a number of other people, they said reduce doesn't make any sense. We should be eliminating health disparities. So the goal became to eliminate health disparities. So my sense was, as the health director for Alameda County, my goal is to increase life expectancy for all residents of Alameda County and to eliminate health disparities. So I thought that's a pretty good set of marching orders. So the first thing I did is I went to my room full of well-educated epidemiologists and I said, what is life expectancy in Alameda County? And they collectively said, I don't know. And I said, well, can't we figure that out? And they said, well, we got a bunch of death certificates. And I said, we do? So we took 400,000 death certificates over a period of about 55 years and put them into a database. And that became the database that launched a whole bunch of studies on life expectancy. So on a death certificate, you can know what somebody died of, what age they were when they died, their race, ethnicity, and where they lived. And those 4 pieces of data can tell you a lot about, over time and over a large body of people, can tell you a lot about patterns of death in a community. So that's the first thing that we did. We actually went back in time and we wanted to look at life expectancy in Alameda County, and we wanted to do it by various race ethnic groups. And to do that, you need the census, and the census only after 1990 started talking about populations other than white and black. So if you wanted to go down before 1990, which we did, we wanted to go back as far as we could, you could only compare white and black. The other group was other, which was a mix of literally everybody. And what we noticed was that in 1960, life expectancy difference between whites and blacks in Alameda County was 2.3 years. 20 years later, it had more than doubled to almost 5 years. And then 45 years later, it had almost quadrupled to almost 8 years. And this is during a time of revolution in healthcare, with CAT scans, PET scans, minimally invasive surgery, pharmaceutical wonder drugs, all of these things that were coming online. And during that time, you see a widening of this gap. And some people would point out that, as a health director, I actually was almost doing my job. Life expectancy for both of these groups was increasing. But if you went past the first goal of Healthy People 2010 to the second goal, which is to eliminate health disparities, I should have been fired, because on my watch, this gap was growing. And the sad truth is that nobody held me accountable for that. So in order to be held accountable for that, I had to produce the data, get it on the front page of the San Francisco Chronicle, and then say, I should be blamed for this, which means I should also get the resources to actually address this. We don't hold ourselves accountable for these things. We don't. There's no financial disincentive to sort of watch this all happen. We publish reports which say that we're failing, and there's no consequence. That's a problem. The other thing you can do with these death certificates, obviously, is you know where people lived, is you can actually calculate average life expectancy for every neighborhood in your jurisdiction. So we did that. These are census tracts. There are about 150 of them in Alameda County. There are about 10,000 people living in each, so that's enough of a denominator to calculate a rate. So we calculated mortality rates, which you can convert into life expectancies, and these are essentially, this is the distribution of life expectancy in Alameda County. Those red areas are where people can expect to live only about 74 years. The green areas are greater than 80 years, and the yellow areas are in between 74 and 80 years. And this was not only shocking to my epidemiologist, it wasn't shocking to me, because I had been in East Baltimore, and I thought, there's no way this isn't impacting people's life expectancy. The epidemiologists were shocked. This ended up on the front page of the Oakland Tribune and the San Francisco Chronicle, and it drove a lot of conversation about what we ought to be doing about this. One of the things that I heard when we first presented this, if any of you have seen the documentary Unnatural Causes, this was one of the pieces of data that actually led to the creation of that documentary. But one of the conversations I had with people after they saw this data was people would, and it was sort of funny to me, which is why I like questions, because whenever I get a really interesting question, I usually make a slide about it. And so my slides are all the product of interesting questions. So somebody said to me, wow, there's a lot of inequity in Alameda County. And I said, yeah. And what else do you see in this graph? And they're like, that's it. And I said, no, this is not just Alameda County. This is happening all over this country. This is just an example of how we distribute opportunity. So as a result of that, I had to start going around the country and looking at other places. So we had some friends in Cuyahoga County, Cleveland, who did a similar map, which also ended up on the front page of the Cleveland Plain Dealer. I had to go back to Baltimore, do this analysis with the Baltimore City Health Department, and this ended up on the front page of the Baltimore Sun. There are neighborhoods in Baltimore where average life expectancy is 58 years. 58 years on average you can expect to live in some of those neighborhoods. That is not even third world statistics. That's like fourth world. And that's in the United States. And that's today. We went to Los Angeles, replicated the same study, Seattle, King County, New York City, Philadelphia, Minneapolis, Boston, Denver, Detroit. Everywhere we looked, we found life expectancy differences in the same city on the average of 10, 12, 15, 20, 25, and in one case, 30 years. And you cannot explain this data. The longer version of this presentation actually tries to show you that the correlation between these outcomes and access to health care doesn't exist. This is not driven by access to health care. And it's incumbent upon us, I'd love to see Omaha's data. It's incumbent upon us to explain this. And our explanation to date is that it's bad behaviors, that people with very bad health behaviors concentrate in certain neighborhoods. As if they're like, hey, who are the smokers? Let's move over there. And access to health care. And neither of those things explains this. There are much deeper explanations for these things. And until you can understand this, you're not doing health equity. You're doing something. It might be well-intentioned, but you're not doing health equity. You have to understand what are the root drivers in your community of these differences, these fundamental differences in health status. We did the whole state of California, and we now have a little widget on our website that you can put in your address in California, and it'll tell you how long you're going to live. And people love it. They go to the site all the time. They want to know. It's great information, right? So you can make plans about, what you're going to do with your estate. The other thing you can do is, I'm a data junkie. I love numbers. And you can take the life expectancy map and correlate it with the poverty map from the census and come up with a simple bivariate correlation, which basically allows you to predict essentially the relationship between income and life expectancy. And so on the up axis, you've got life expectancy, and on the lower axis, you've got poverty rate. And you're moving from the left to right. You're moving from relatively wealthy communities. So each of those blue dots is a community. You're moving from relatively wealthy to relatively poor. And as you move from left to right, you see life expectancy gets correspondingly shorter. This is the cost of life. In Alameda County, there's a death tax, and the tax is higher for those who live in low-income communities. We did the same thing for the entire San Francisco Bay Area, did the same thing for the entire state of California, and in fact, for the Bay Area, you have to translate this stuff. You can't put a scatter plot on the front page of the newspaper. So we translated it to just monetizing the slope of that line. Every additional $12,500 in household income buys you a year of life in the San Francisco Bay Area. That's the cost of life. That's what we're worth. And we encourage people to use that kind of data when they're negotiating their raises. You know? You got to bring this kind of data to the table. Like, boss, I need 2 years. I've been working hard. I deserve those 2. Tony, I don't know. That report was late. I'm seeing 6 months for you tops. Okay, and then this question about sort of the larger American health, because whenever you talk about health disparities, people say, oh, well, that's other people. That's not me. And I'm not to blame. That was historical. Stuff happened. It's getting better. It's not me. Don't worry about it. That's the kind of feedback I get often from very well-intentioned people. But let me, and thankfully I have a friend from Scott County, Indiana, who knows that that's not entirely true. The state of American health is not good. In fact, as a health disparities researcher and practitioner, we routinely use white mortality rates as the standard. So you compare African mortality rates in various diseases to white, you compare Native American, you compare Latino. In fact, in California, Latinos and Asians, it's kind of hard to make the comparison because they have better rates than whites. But white mortality rates are getting so bad now that they are really not a good benchmark against which to compare other groups. And let me show you some evidence of that. First, I want to talk about this data that you've all seen before. We spend a lot of money on healthcare, a lot, and much more so than anybody else in the world. We spend more than twice the OECD average. So we double down on healthcare compared to our peer countries. Everybody knows that. That's not news to any of you. We know that as a result of that, we get relatively poor outcomes. Given our spending, we should be at the tip of that black line, but instead we're well down from where we should be, at least in terms of life expectancy. So we spend a lot and we get relatively little. Now that should provoke some sort of critical thinking. Apparently it has not. But there are other ways of looking at this data. This is 2 women, Lauren Taylor and I'm blanking on the other one's name, one at Harvard, one at Yale, who produced a little analysis that they did. They're health services researchers, and they did a little analysis with this data that all of us have been looking at for years, those blue lines, which are per capita healthcare expenditures in the United States and various other countries. What they did, which nobody else had presumably done before, was they added to that the per capita expenditures on social services or social benefits. And when you do that, the US is no longer the outlier. We're not the big spender. We just happen to have our accent on the wrong syllable. We spend our money on health care. Most of our peer countries spend more money on social benefits and social services and get better health outcomes. In fact, they correlated health outcomes with social spending versus healthcare spending, and they found that the ratio of social spending to health spending actually predicts life expectancy and a whole host of other health outcomes. So if you want good health, you should spend it on social benefits. Okay, so this was in the New York Times, and it got so much attention that they wrote a book. It's called The American Healthcare Paradox. It's a pretty strong argument that we've got our spending priorities screwed up, yet we haven't seen much change. Okay, so white Americans, the benchmark. Life expectancy about 79 years, which is about the same as Qatar, Costa Rica, and Nauru. Okay, so U.S. whites are living shorter lives than Belgium, Chile, Denmark, Lebanon, Slovenia, Austria, Finland, Germany, Greece, Ireland, Malta, the Netherlands, Portugal, the UK, Canada, Cyprus, France, Iceland, Israel, South Korea, Luxembourg, Monaco, New Zealand, Norway, Sweden, Andorra, Australia, Italy, San Marino, Singapore, Spain, Switzerland, and Japan. There are 33 countries that have longer life expectancies than U.S. whites. In 1990, there were only 17. U.S. white life expectancy is plummeting against our peer nations. How many people knew that? This is critical. The recognition that our incentive structure is skewed. And in order for us to address this in Omaha, we need the healthcare system to lean in to the community. We need the healthcare system to look at its incentives and think about larger incentives in the community to participate through partners and in many cases directly as a neighbor in Omaha, a big neighbor, to drive changes in measures of health status that are important, and certainly measures of health disparity. Okay, one of my colleagues, Dr. Stephen Wolf at Virginia Commonwealth University, was the lead author on this IOM report, which says it much better than I can say it. The report was looking at U.S. Health compared to 17 peer countries around the world. It came out a couple of years ago. You know that the news is not good when the report's entitled Shorter Lives, Poorer Health, talking about the U.S., and their conclusion was the panel was struck by the gravity of its findings. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 3 decades, especially among women. The U.S. health disadvantage cannot be fully explained by the health disparities that exist among people who are uninsured or poor. This was my point earlier. People think, oh, it's all health disparities. If you took, all of those people of color out of the data, we'd have great data. Wrong. Our data is actually bad. It's bad across the board. Health disparities exist, but we have regular old disparities compared to the rest of the world, that is American health. Several studies are now suggesting that even advantaged Americans, those who are white, insured, college-educated, or upper income, are in worse health than similar individuals in other countries. Some of you may read the New York Times, the Washington Post, the Wall Street Journal, and have seen the work of Angus Deaton, an economist, and his wife, Ann Case, who have been reporting on this really a crisis in white mortality happening in the United States. This is looking at mortality rates now. You want mortality rates to go down, and in fact, over the past 100 years or so, they have been going down in this country, with a couple of exceptions around the HIV/AIDS epidemic and then the 1918 world flu. We have seen a decline, a relatively steady, although slow, decline in mortality rates across all groups in the United States. Over the past 20 years, you cannot say the same thing for white Americans. And this is what Deaton's data suggested. Looking at all of these other countries, looking at U.S. Latinos, that red line is U.S. whites. And this is astonishing. This is something that's really, literally unprecedented. My work is really about trying to have conversations. And we're focused in California. We're an organization that is spending about $1 billion over 10 years trying to measurably improve the health status of about 1 million people in 14 communities across California that represent the demographic diversity of California. And our goal is to essentially improve health status with one caveat, and that is that we will not spend a nickel on health care. So this is a purely social determinants of health investment strategy. And it's an experiment. And it seems to be working, and I can tell you a little bit about that in a second. But part of this is focused on changing the narrative. Most people don't know this data. Most people who work in public health don't know this data. And certainly most people who work in healthcare don't know this data, in part because the incentives are not there for people to understand what the health of their community is and some of the predominant trends that are happening in the United States and have been happening for 20, 25, maybe 30 years. And they're early warning systems that have been alarming across this country about our health status, and we have not been picking up the red phone. So we spend a lot of time talking to people about real life expectancies, real zip codes, real high school graduation rates, real zip codes. When Sacramento, which is our capital, built its new airport wing, we decided we were going to have a conversation with our legislators on the walls of that airport. And so we put up these billboards, and all of a sudden my phone started to ring off the hook from legislators asking me why I was decreasing property values in their districts. And when the American Public Health Association meeting was held in San Francisco, we decided to literally festoon downtown San Francisco with the signs. This is Governor Schwarzenegger's office a few years ago, where we, for some reason, he let us put this up outside of his office for four months, which stimulated a lot of conversation and a lot of press. So our goal is essentially to kind of elevate this conversation in the narrative, to get people to start talking about some of these drivers. When you see your zip code and a life expectancy next to it, it makes you think. When you see a map of your community and you see your neighborhood with a life expectancy assigned to it, it makes you think. You need to actually bring this conversation up into the forefront, because still the conventional narrative about health is that it's about access to doctors and behaviors. And those two things matter. Don't get me wrong, they matter. But they don't matter nearly as much as the environmental conditions that we construct for people and then have them navigate to pursue health. Okay, so 80% of what affects our health status happens outside of the doctor's office. 80%. But the gentleman over there pointed out that the health system doesn't have the incentive to step out beyond that 20%. And so we have a problem. Again, it's the accent on the wrong syllable. And the question is, how do you actually get the healthcare system incentivized to participate in partnership, in community, to try to improve these health statistics that we know are generating enormous demand on the healthcare system? That's the question. So let's first think about what's happening to people. First of all, I don't know Omaha well enough to tell you, what is a neighborhood in Omaha where there's high poverty and high health disparities? Let's talk about people living in North Omaha. So they're struggling presumably with a lot of risks in their immediate vicinity. And when you have risks, just like any other human being, you have stress. We all have stress in our lives. The difference is that people in North Omaha maybe don't have the resources to contend with that stress. So they're constantly being bathed in cortisol. They have chronic stress. And what we know about cortisol is that actually over time, it's good for you acutely when you're under acute stress, but when you're chronically stressed, it changes your physiology. It does a whole host of things, which I'll talk about in a second. It not only changes your physiology, it changes your behavior. It makes you crave certain types of food. It might make you crave drugs in Scott County, Indiana, or in North Omaha or elsewhere. It might make you crave cigarettes or alcohol. It not only changes your behavior, it actually changes your genetic expression. Through epigenetics, it changes the way your genes operate. Very simply put, take two identical twins, put one in North Omaha and put another one in Beverly Hills. Their genes will express themselves differently. Okay, so this notion of allostatic load or chronic stress is the best way to understand what's happening to your patient who lives in North Omaha, who comes to see you in a 15-minute encounter, and you can't understand why that person is so wound up and so resistant and so non-compliant with your directions. So how do we interpret stress? We all know this, that we perceive the stressor through our brain, primarily through the hypothalamus, which sends a message to the pituitary gland, which sends a message to the adrenal glands, which release a cascade of hormones, amongst which cortisol is one. And in the acute period in the blue, cortisol is actually useful for you. It stimulates your cardiac output, it rallies available glucose, it enhances your immune functions, turns down your inflammatory system, which is why we give steroids for inflammation, and it stimulates growth of neurons in your hippocampus and prefrontal cortex, which are necessary for what's called executive function. And a very simple way of describing executive function is being able to choose between a set of options, some of which are short-term, intermediate term, and long-term, and make the best decision for you in that moment. Now, in the red, when you're chronically bathed in cortisol, and just think about these, those red areas I showed you on the map of Alameda County are incubators for chronic stress, like North Omaha, where people are constantly awash in a fog of stress. They're just looking at risk, 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 and they're trying to navigate this on a daily basis. So that stimulates almost the exact opposite of acute cortisol. It stimulates hypertension, cardiovascular diseases, glucose intolerance, and insulin resistance. It turns up your inflammation, turns down your immune system, and it actually causes atrophy and cell death in that same part of the brain that I said was necessary for executive function. And when I talked to a lot of police officers, work with the Department of Justice, talking about this stuff, and cops invariably come up to me and they say, I know what that looks like. It's a look in the eyes of people that I deal with every day. It's like they're lost. They can't find their way forward. And that's chronic stress. That's allostatic load. And as I said, it changes your physiology, it changes your behavior, and it changes your genetic expression. It's fair to say that low-income people in this country, because of the conditions that we make them live in, are physiologically different than high-income people. Not because they were born that way, but because we made them that way through our policy. Or more oftentimes, it's the absence of policy in the face of abject need. And that's on us. And we try to manage that in 15-minute clinical encounters in fancy medical centers like this. So people living in these kinds of environments, you see health disparities. And we call them health disparities because we're inarticulate. What we're actually seeing are health inequities that have been societally structured. And in order to understand disparities, you have to get under the surface and understand what the drivers are. And then you have to figure out how do you participate in reshaping those drivers. So a group of us in the San Francisco Bay Area, a bunch of frustrated public health officials, came together because we felt like the challenges that we were facing, these socially mediated health challenges, were overwhelming compared to the traditional tools we had in public health. The traditional tools in public health are literally clinics and brochures. I mean, that's pretty much what we do. We say, don't smoke, here's the brochure. Eat better, here's the brochure. We don't say, don't be poor, here's the brochure. We probably should. But so traditionally we operate in this medical model, which, reading from the far right to the left, starts with sort of premature death. If you want to avoid premature death, you have to figure out that that's driven by high rates of disease and injury. So you want to intervene there. And high rates of disease and injury are driven by behaviors, either risk behaviors or sort of general risk factors, which may or may not be genetic. And so this medical model is focused on individuals, but it doesn't really anticipate sort of this larger socio-ecological space where so many of the drivers of the downstream medical conditions are located. And so in the socio-ecological space, we talk about social inequities, which are neighborhood conditions, residential segregation, in some cases workplace conditions, that are driven by institutional practices and policies that create those conditions, which are ultimately driven by what I started with, a narrative. The stories we tell ourselves about who we are as Americans, who matters, who's deserving. This whole story about Horatio Alger, pulling yourself up by your bootstraps. And the funny thing is, this is what I just enjoy this, is that, at the end of my talk, I always have somebody, it probably won't happen today because I'm telling you it happens. Somebody comes up and tells me, you know what, I really like what you had to say, but it doesn't apply to me. My grandmother grew up in the worst tenement in the Bronx. She had to walk uphill to and from school every day without any shoes in the snow and rain and thunder and lightning. And she fought hard and she persevered, and today she's the CEO of Xerox. And if she can do it, anybody can do it. And I always find that really interesting because that's the American story. That's what we tell ourselves, that you can persevere, you can pull yourself up by your bootstraps. And the fact is that woman's story is completely true. It is absolutely true. but it's highly unlikely because the odds are stacked against people like her grandmother. So just because her grandmother overcame the odds doesn't mean that everybody can. In fact, almost by definition, the fact that she's telling me that story suggests that it's unlikely. So rather than helping people beat the odds, we need to change the odds. And that's what this work is about. It's about using all of the resources at your disposal to increase the likelihood that more of these people living in North Omaha under huge allostatic load burdens can actually overcome that and participate more gainfully in the 21st century economy. So that's what this model is about. If you're looking at health disparities, you're talking downstream. If you're upstream, you're talking about health inequities. And you can take the word health out of that and just talk about inequities producing disparities. And if you're simple-minded like me, you talk about conditions producing consequences. And we spend an enormous amount of money in the consequence management game. You can actually change the downstream outcomes out of health and make them educational, where school absence and truancy leads to grade failure, which leads to dropout, which is correlated with very low life expectancies over time, as well as poor economic criteria. So the point is that the downstream set of situations is all dependent on the same upstream drivers. Now, I want to be very careful here because this is always where it gets a little tricky for people. Downstream is critical. We have to do it. When you walk into a community and there are fires burning, the first thing you do is you grab a hose and you put out the fires. And then you high-five your buddies, you go drink a Budweiser at the local bar, and it's a commercial and there's a Dalmatian dancing on the table. You go home, you go to sleep, you get up the next day, you go back into the community, there are fires burning in the same places, the very same places. What do you do then? You pick up a hose, you put out the fires, but now you're thinking, maybe I don't want to go to the Budweiser commercial, maybe I'm going to go home and think about this. The third day, you get up, you come back, the fire's burning in the same place. You're like, okay, this is crazy. You pick up a hose, you put out those fires, but you're thinking, what's causing these bloody fires? I got to figure out what's causing these bloody fires. And that's what this work is about. So you never stop picking up the hose. As an internist, I treat people. But that's not all I do. I think what's making it much more likely that this person's going to come back to me in worse condition. And that's what this work is about, figuring out what's causing those fires. It's not saying that putting out the fires is not important. That is critical. We just want to put out fewer fires. So upstream, we've translated that practice because we don't have an organized way of thinking about it. We're trying to organize that. We've translated into looking at the narrative, which produces the policies, or as I said earlier, in many cases, the absence of policy in the face of abject need that creates conditions oftentimes manifest in place, like North Omaha. And what's critical to this is to enlist the participation of the people who are most impacted by the inequities. The people who feel a lack of agency, a lack of control over what's happening to them. One of the best ways to improve their health is to help impart to them a sense of control over what's happening, both individually and then collectively as a community. So our practice in trying to address this involves organizing people, bringing them together so that they see similarly situated people working together to make change in their communities. We think that that's not sufficient, but it's critical. It's the cornerstone of this work. We also have to look at policy, and particularly the health impacts of non-health policy, like tax policy, like education policy, like land use policy. And institutions like this can have a big role at the table because you have credibility and you're a major political actor in the city of Omaha. But we think that that's not sufficient. You also have to look at the narrative. We have to re-understand what produces health in our communities. And we have to understand disparities and what's at the root of that and the historical legacy of discrimination and oppression and segregation that created the conditions that many people are living with today, but also recognize that this is not just disparities. This is impacting all of us. And I started by telling you about Canada, where I grew up, which is not a perfect country. I mean, play a lot of hockey. A lot of us have lost our teeth playing hockey, which is why we have dental care for kids. It's not a perfect country, but it has a solid social compact. There's solidarity across race, across place, across class. In this country, I put it to you that what's missing is that sense of solidarity. We need to create a stronger sense of solidarity, and that's all about narrative. That's all about who we are as a people. Okay, so very simply, the medical model says that bad behavior produces high rates of disease, which produce premature death. And the socio-ecological model says that bad societal behavior, both historically and continuing, isms, sort of a false narrative, a narrative that excludes people, creates policies and practices that create communities that are on life support. And then we try to manage these communities with drugs, quite frankly. We have interventions to try to prevent death. We call those emergency rooms. Interventions to try to manage disease. We call that clinical care. We have interventions to try to change behavior. We call that health education. And that altogether is a $3 trillion enterprise, and growing. We don't have organized interventions to try to address North Omaha. We say, it's terrible up there, it's too bad, I hope those people can get out of there. And we celebrate in the newspaper a story on a kid in North Omaha gets a perfect SAT and goes to Harvard, Yale, and whatever. And it's like, yay, great. And that's exactly the wrong story to be celebrating. Of course there are kids out there that can go to Harvard and Yale and whatever. The story is that we don't get more of them there because we don't work on changing those odds. So our strategy for addressing neglected communities is building power and leadership in a critical mass of people in those communities so that they can more effectively participate in the policy making and decision making that's shaping their environments. That's not sufficient. You also have to look at the policies and create partnerships across silos, across disciplines. The health agencies have to be working with the land use agencies, have to be working with the police, have to be working with education to find common purpose. And that's not sufficient. We have to change the narrative about who we are as a people going forward into the 21st century. We call these the drivers of change, and it's the root of our practice that we have in California in building healthy communities. Now, I'm going to stop very shortly, but first I want to talk a little bit about what is the role of a health care institution in this work. Because many people say, Tony, you're a really nice guy, I agree with everything you're saying, but this is not relevant to what I do on a day-to-day basis. And I say, okay, let's talk about that a little bit. First of all, you work in an institution that consumes an enormous amount of resources. Enormous. So you have an obligation right at the top of that to recognize, is this the best use of these resources for this community? And how can I ensure that these resources inure to the benefit of the entire community? Who do we hire at this institution? Are we an economic engine for people in North Omaha and other parts of the city that are clearly experiencing very high levels of unemployment? Do we create unnecessary barriers to hiring people? Where do we procure our resources from? Do we make sure that we are identifying areas of our community where we can actually provide resources that circulate in that community to benefit those populations? What kinds of environments do we create in our clinical space? Are they welcoming? Are they culturally appropriate? Do people feel like this is a place for them? Do we use peer-based practices clinically where somebody from North Omaha can actually see themselves as an asset, an expert, if you will, working with somebody else from North Omaha, helping them navigate a set of challenges that they both share and experience? Do we lean in to the community? Do we participate in civic matters as an institution on behalf, not just of ourselves, on behalf of our workers, thinking about housing costs, education costs, crime, land use, Do we participate on behalf of our patients in decision-making processes? There are formal ways that we can actually, as an institution, lean in to our community. Do we care what the obesity rate is in Omaha? Does this institution care? And if so, what have we done about it? Do we care what the smoking rate is? Do we care what the asthma rate is? I mean, these are real questions. I mean, you may be saying, yes, 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 we do that, we do that, we do that. I'd like to know about that, actually, in the conversation. Do we care about the high school graduation rate? Do we care about the high school graduation rate for African American boys? Do we care about the third grade reading skills of all, and particularly for African American boys, Native American boys, and other groups that have traditionally not fared well in those measures? And what are we doing about it? Because that's leaning in to the community. That's taking ownership of this issue. And that is creating incentives on yourself. As I said in this work, I was always surprised that nobody held me accountable for anything that seemed to matter. I was held accountable for things that didn't matter at all. The wealthiest part of my community, I would get yelled at by the politician who represented that community because I didn't hold a free flu clinic in a neighborhood that had literally billionaires living in there. Whereas in the low-income part of town, nobody ever yelled at me for that, or anything else, quite frankly. I would get yelled at from people who had privilege and resources. And those kinds of incentives need to change in order for this work to change. I will say lastly that places like Omaha, and I know this for a fact because you've been engaged in collective impact, and you have some model citizens here that are doing some wonderful work around trying to build up housing that's dynamic, that has education associated with it, and has wellness and other resources associated with it. Communities like this where people know each other, where people don't live in high silos that are rigid and apart from each other, do better in this work than places like Los Angeles or New York City. Because you wear multiple hats. You may be on the city council, and you may be a volunteer fire person. You may teach softball to the mayor's kid. So you interact much more easily. And that is a huge advantage in trying to do this work. Because you don't see yourself just as this institutional entity. You see yourselves as part of this community. And for this work to happen and to happen well, people have to be able to empathize with others, they have to be able to have relationships with others, and they have to see themselves as more than just their job. And I think that in Omaha, you guys have that. You have that advantage. And I'm looking forward to hearing about the work that you're doing. I appreciate you inviting me here today. I hope I haven't left you too depressed. In California, we're very excited about what we've been able to achieve in this work. And in the Q&A, depending on how much time we have, we can talk a little bit about that too. So thank you very much.